Aditya Sudhalkar. Dr. Aditya Sudhalkar is a consultant vitreoretina surgeon at Sudhalkar Eye Hospital and Retina Center, Baroda, as well as Raghudeep Eye Clinic in Ahmedabad. He has several years of experience in vitreoretinal surgery with several publications, and his areas of interest include diabetic macular edema, detachments, and he's written a book on minimal surgery for retinal detachment. So with this, Dr. Aditya, he'll be speaking on the real world experience with brolucizumab.
Thank you so much, Dr. Anirudh, for such a kind introduction. And in the interest of time, I've shortened my talk to 2 cases each from Germany and India. And these are just pictures from our clinic in Germany. Just like to state at this point that I have full rights over whatever data that I'll be presenting from Germany. So coming to the cases, this was a 74-year-old retired physician from Bremen who presented to us with metamorphopsia since 4 days, diminished reading ability. So the vision in the left eye was affected, and the anterior segment examination was quite normal except for the presence of pseudophakia. Now the clinical photos, the angiography, and the OCT scans were in line with what one would expect with a type 1 CNV. Now, just to give a heads up to everyone, in Germany, the protocol is for all macular disease, you give treat and extend. That is, all patients are initiated with 6 monthly injections, either of aflibercept or ranibizumab. If it is AMD, then we necessarily have to begin with aflibercept. And regardless of the response to the first 2 or 3 injections, we complete 6 consecutive monthly injections. After that, we increase the treatment interval in 2 weekly spurts. And at any point in time, if it is felt that the fluid is recurring, you shorten the interval correspondingly by 2 weeks. Now, with the Altair study, there is an allowance for 4 weekly increases in the treatment interval. And you can extend the treatment or maintenance therapy to a maximum of 16 weeks, which would essentially mean 3 injections a year with aflibercept. So now in this patient, unfortunately, despite regular therapy, he continued to worsen. So we see increasing fluid in all compartments along with this choroidal cleft, which becomes more and more prominent at varying time points, as the disease progresses. So despite 6 consecutive injections of aflibercept and then switch overs to 6 consecutive injections of ranibizumab, he continued to worsen. So in March this year, he finally received his first brolucizumab injection. The first itself showed a significant change, not only in the fluid, but also in the reduction of this cleft. And it almost became normal. I mean, at least the exudation resolved with the second one. He received since this was not a naive patient, he just received 2 injections. We saw this recurrence at 12 weeks, following which he received his 3rd injection. And now he has been put on maintenance therapy. So for brolucizumab, the German protocol states that it is 3 consecutive injections, followed by a follow-up at 8 weeks as per Hock and Harrier, and then a mandatory injection at 12 weeks. The second patient I'm just going to skip because it's a routine case and there's in the interest of time. But this patient is interesting. So this was a 69-year-old Arab refugee who presented to us with metamorphopsia and an inability to pray since 1 month. Her vision was obviously affected. And she was phakic, so nothing significant in the anterior segment. So the angiography and the clinical picture showed a very evident CNV. Now here, if you see after the first injection itself, it was nothing short of a miraculous response. And the second nearly resolved the disease. Of course, we still see the evidence of CNV with the double hair sign and everything. So she has been put on 3 consecutive injections and she has received her 4th injection as well last month. So to summarize our experience in Germany of 30 patients with a 6-month follow-up, it is even in a small setup such as ours, and a weekly count of 30 patients is not uncommon in Europe and the US. So 12 of these were treatment naive and 18 were switch patients, which was understandable given our reluctance to use the drug in naive patients from the word go. However, the next 30 patients are more or less half and half. The findings are also in line with what one would expect, but the most important is that we have had no instances of inflammation or vasculitis thus far. There have been 3 or 4 reports of TAS-like or sterile endophthalmitis in Europe, but not in Germany. Also, I would also like to say that I think out of the 12 treatment naive patients, 7 of them completed successfully the first Q12 quarter, which is considered an important landmark as per the Hawke and Harrier. So coming to the Indian cases, this was a 65-year-old male who presented to us with metamorphopsia in the left eye since 3 days, and he had a history of recent cataract surgery a fortnight ago. So the vision was not too bad, but the Amsler test was positive, and he had his OCT angio and FFA done elsewhere. So these are scanned images, and I apologize for the poor quality of the images, but this is what it looked like. Now, what is interesting in this patient is that the right eye also shows evidence of subclinical CMM. So what we see here is this is the right eye OCT, and it has continued to progress, but it has never reached the fovea. So he's asymptomatic. He has not received any treatment over the 3 years of follow-up that we have had, and he has not had cataract surgery in the right eye as well. But the left eye continued to worsen despite reasonably regular therapy. So he's had about 17 Eylea injections, 7 or 8 Accentrix injections, or ranibizumab, 3 or 4 biosimilar injections, and 2 or 3 Avastin or bevacizumab injections. But he continued to worsen, and it was a very aggressive CNVM. Now, in this case, what ultimately worked was a combination of Ozurdex and or the dexamethasone implant and aflibercept. So whatever is going on in this patient is between the fovea and the disc. But this is what worked, and you can see the implant in C2 here. But 6 weeks later, we were back to where we were. So at this point in time, we injected brolucizumab because it had become available in India. And I'll skip the interim follow-up, but this is what it looks like at nearly 6 weeks after the injection. So what we see here is the scan was done elsewhere. The patient is currently in the UK. There is obvious swelling here, but at least the center is fluid-free. There is obvious destruction of the retinal architecture as well, and for the past year, his vision has not gone beyond 660 or 636. This is just from the right hand. What we see here is that there is evident fluid with some subretinal fluid here as well, but he's still asymptomatic, and which is why we have continued to defer treatment in this patient. This was just a follow-up at 1 week that we had for inflammation. We did a peripheral indirect examination, no evidence of inflammation or vasculitis. And we have been in constant telephonic touch with the patient throughout the course of follow-up. The second patient here, this is what he presented to us with. So he has been a regular patient of ours since 2016. So this was the primary OCT, but when he actually came back for treatment, which was about a fortnight later, he had already had a RP rib. So this obviously compromised his vision, but notwithstanding the rib, he had maintained very good vision until 2018 or 19. So just to cut a long story short, he became recalcitrant to both ranibizumab and aflibercept during the course of therapy. And at this point in time, we injected brolucizumab. Now we only have a 7-day follow-up because it's due for his follow-up next week. So we hope to have more data then. But as you can see, he has responded quite well to an injection. Even the first patient that we did, we had counseled him for steroids here. We just heard an extensive talk on that by Pradeep sir. And given the inflammatory nature of the CNVM, but this patient had apprehensions about the possible negative effects of steroids. And he knows several doctors in the US personally, Dr. K.V. Chalam being one of them in Jacksonville. So he deferred his injection to nearly 3 years, unfortunately, to his detriment. So thank you very much for your attention. Dr. Anirudh, over to you.
Thank you very much. I think that was a very interesting experience that you shared on follow-up of patients treated with different therapies and with brolucizumab. So at this point, if there are any comments from the panelists, Dr. Vishali ma'am.
No, I think there are 1 or 2 questions which you have to. There is one for Rima privately.
There's one question in the chat for Dr. Rima ma'am, which says, in these patients, when you're giving intravitreal injections, would you recommend doing anterior chamber paracentesis? And does that lead to inflammation? Do you avoid doing it?
Can't hear Rima.
Can you hear me now?
Yeah.
Yes, ma'am.
The question is, should we do it or should we not do it? Could predisposed should best be avoided. I think it's not the anterior chamber tap that is predisposing to inflammation. So if you are in the habit of doing an tap in all the patients and they are behaving all the same, it's fine. But if you happen to observe it in a patient where you've done it and where the inflammation is more, then you need to keep a watch. But if you consistently do it in all patients and you develop in only one, I don't think that should be the reason for it.
Yeah.
Thank you. I think we have a lot of evidence now coming in support of how the inflammation should be tackled with brolucizumab and how these patients should be followed up. So I think that's a very good initiative. And just Dr. Borse, since you couldn't share your slides, can you share your experience, like personal experience, on how you think brolucizumab works in your patients? If you can summarize in like 1 or 2 sentences.
I think Anirudh is not able to.
Who's careful enough to respond back to us if there are any untoward effect. Like I tell them that anything out of the way, please come back and report to us. And we have to definitely investigate and examine the eye carefully for signs of any old vasculitis or any inflammation. Because as per the advisory, if you already have an existing or a pre-existing inflammation, the chances of you landing up with an intraocular inflammation is much more with brolucizumab.
Would you be, worried about using brolucizumab in a patient practically one-eyed or having only good vision in one eye as of today?
Yes, definitely. I mean, if you will use it only if you have exhausted all your other options. And as of now, till the time we get a hang of it, I think it's better to avoid that.
Yeah, I think that's an important issue. I think one-eyed patient, we can avoid altogether. And if we want to use it, maybe in a second eye, where everything else has failed, you use it to gain the initial confidence, because that is where the problem is. If we don't have a confidence in using it, and we find that we might land up into a trouble with a severe occlusive vasculitis. We're talking of occlusive vasculitis, not a simple vasculitis. So I think maybe if we start that way, avoiding one-eyed patient and only the second eye of where you have exhausted most of other things and you use it, maybe your confidence building would be there and we'll have a more experience pulled in. It has to come in from, I think, everybody. Maybe VRSI or some agency has to coordinate to get then we'll get a confidence to use it. Otherwise, it seems like a very good drug, but I think this occlusive vasculitis business has really kind of put a little thing on it. So in fact, in my own center here where I work now, we did get this is already procured, but we have not had a heart to use as yet. So that is where we stand.
Now, I've used it in 3 cases with very good experience, but like I told, we have to have a very informed and a very aware patient who can come to you, because the vasculitis is after prolonged inflammation. So, if they come to you earlier, it is always better to treat the inflammation at the earliest to prevent a further vasculitis in these cases.
Besides vasculitis, there are also reports coming of arterial occlusion.
Yes.
So that is after 3rd or 4th injection because of anti-drug antibodies. So we need to look at a lot of aspects.
Absolutely. Absolutely. We need to.
So I think in the next few months, we need to build confidence on brolucizumab, as well as probably the COVID vaccination. So I think they're going to go hand in hand. So hopefully 2021 is going to bring a lot of optimism on patient outcomes with these newer agents like brolucizumab. And I think we've overshot already. Thank you once again to Chandigarh Ophthalmic Society, Dr. Vishali Gupta, for chairing this session. All the panelists, Dr. Dogra, Dr. Borse, Dr. Aditya, Dr. Banker, for joining in, our guests, and our speakers also, Dr. Reema Bansal, Dr. Pradeep Kumar. And thank you very much to Novartis for organizing this. And I'll just hand over to Dr. Vishali for her final concluding comments.
And I'm thankful to everybody, COS, Novartis, all the speakers, especially dedicating their Sunday morning to us. And I think Chintan is here on behalf of COS. She'll say the final word.
Thank you, ma'am. Thank you, Anirudh. And thank you, everyone. My apologies for not being here in the beginning, but I'm sure it must have been a very successful webinar. And I don't think I will take too much of everybody's time now, since it's already a Sunday afternoon. And special thanks to our guest speakers, Dr. Ale Banker, Dr. Nishikant, Dr. Pradeep, and of course, Professor Dogra sir, and our own faculty. Thank you, ma'am. And thank you, everyone.
Thank you, everyone.
Thank you.
Thank
Good
you.
day. Bye-bye.
Thank you.